The next speaker, Professor Attila Kardos. Professor Kardos is a consultant cardiologist in Milton Keynes. He's also Associate Director of Research and the Director of Cardiovascular Research Group. He holds many more seats in various prominent roles, nationally and internationally, too many to mention here. I don't think Professor Kardos needs any further introduction. He's renowned in the world of stress echocardiography, and tonight Professor Kardos is going to give us a masterclass in the value of stress echo in ischemic patients. Thank you, Professor Kardos.
Thank you very much, Raniet, and let me just see whether I can activate my slides here. Can someone just tell me that? Fine, thank you. So first of all, I would like to express my gratitude to Bracco, Gianfranco, and Jerome to pull up this very interesting topic of discussions and make this webinar to happen. It is a very topical issue to discuss. And I have been given an invite to talk about the value of stress echo in ischemic patients, i.e. angina. I'm trying to drive, that's it. Just have to make some adjustment. Right, so over the last 3 decades, what was the most important achievement, or one of the most important achievements of the professional societies, both in America and Europe, was that we have recognized, cardiologists, that angina or ischemia is not only be caused by epicardial obstructive coronary arteries, but also the small vessels, the microvasculature that carries more than 80% of the blood of the myocardium, as well as vasoreactivity, either of the main epicardial arteries or the microvascular circulation that can cause vasospastic angina. The topics, therefore, to fulfill my title on values of stress echo in ischemic patients will cover the following. So I'm going to run through quickly about the ischemia, induction or ischemic investigation of invisible ischemia in patients with occlusive epicardial artery disease, which is our bread and butter during stress echogram that we do. And also to talk about those patients who don't have epicardial occlusive coronary disease but suffer of angina, also known as INOCA or ischemia with non-occlusive coronary arteries. In that subsection, I'm going to bring you into the current gold standard of INOCA diagnosis by invasive coronary physiological assessment. And we are going to see whether the current climate and guidelines would support us to translate this invasive coronary physical assessment in the INOCA diagnosis by doing it non-invasively, that is, stress via stress echocardiogram and multi-parametric stress echo. I'm going to also share you some of the cases, how it works in our lab and in the current climate. So the value of stress echo in ischemic patients, of course, we do know the principle of ischemia induction and detection. We do increase the oxygen demand, oxygen uptake of the heart muscle by different stress modalities, being it exercise or pharmacological challenge. And we are looking at the supply changes in the myocardial level, and we are using image modalities to assess that. It's a quick one to see where stress echo is going to come into by assessing the systolic dysfunction predominantly by looking at the regional wall motion and abnormalities. I'm not going to mention this part of that on the bottom of the ischemic cascade just now. Of course, we can use, as has been mentioned before, different stress modalities. Could be a treadmill, the bicycle, tiltable bicycle exercise test, or pharmacological agents like dobutamine or vasodilator stress. We are then looking at different stages, at different views of the heart muscle response and assess the regional wall motions. This, for example, in these patients, the baseline, the low dose, and the peak and the recovery phase of the dobutamine stress echo in a 4-chamber view, 2-chamber, and a 3-chamber view. And we can use harmonics images if the quality is good enough. It allows us to assess wall motions. Indeed, we are looking at the end-diastolic wall thickness and the systolic excursion of the endocardium to make assessment of the different segments of the left ventricle, being it 16, 17, or 18 segments, to judge whether whether segments have got normal kinetic properties, hypokinesis, akinesis, or dyskinesis, and we are allocating scores to them, and we derive a wall motion score index by adding all the scores for the 16 or 17 or 18 segments together and divide by those segments, the number of segments that we managed to image and analyze. Of course, those patients who have got poor endocardial definition, we can use ultrasonic enhanced agent or a contrast agent for short to delineate the endocardial border. These are particles that are the size of a red blood cells that not only give us the blood flow of the left ventricle, but also penetrate down the vasculature of the myocardium down to the capillary level, and can also give us some indications of our blood supply to the myocardium. And again, we are assessing the wall motions by using this. You can also use, and I think some of the stress echo labs are using the perfusion images to look at how the contrast agents, those centers who use contrast, are refilling the myocardium after this high ultrasonic MI impulse or flash that wipes out the contrast agent from the myocardium, and we are looking at the replenishment or the surface of the contrast agent in the myocardium. So that's, for example, a triggered perfusion images shows a very brisk contrast replenishment at the peak lobectomy stress test in keeping with normal microvascular circulation. In the wrong direction. This is a patient referred from a chest pain clinic that has been referred for lobectomy stress echo, multiple risk factors. It's only as young as 46 years of age, but multiple risk factors, typical anginal symptoms. You can see lobectomy stress echo at the resting baseline images show absolutely normal diastolic wall thickening and systolic excursion that augments very well during low dose dobutamine. And when we come to the peak stress part of the test, you can see that the apical segments extensively have thinned out in diastole and became dyskinetic, all in the 4-chamber, 2 and 3-chamber views, giving you at least 5 segments out of 17 of significant wall motion abnormality and high wall motion score index. So this is one to show that we can also look at real-time perfusion images in patients, the same patients that we did that showed before, looking at after the high MI flash impulse. You can see that the apex, the dyskinetic part of the left ventricle myocardium, has got a black rim that takes not 2, but at least 10, 15 heart cycles to gradually replenish, in keeping with significant perfusion problem. Not surprising is that this gentleman had a critical proximal LAD disease on a codominant left system. And that's exactly the value of the contemporary stress echocardiogram in patients with chest pain to diagnose obstructive epicardial carotid disease. What do the guidelines say that have been updated, both the European and the American community? The Europeans are 2019 and the American chest pain guidelines in 2021. For INUCA assessment, you can see that those patients with stable chest pain with no previously known carotid disease and intermediate and high probability based on the typicality of angina, gender, and age, they would benefit, and they have got a class 1 recommendations to undergo stress testing, amongst them stress echocardiography. Those patients with previously known coronary disease that have been classified more than 50% at that time. If optimized medical treatment does not work, in addition to risk factor modification, unless the patient has got high risk feature, either crescendo angina, unstable angina, in which case they should go straight in the cath lab, they will also be recommended on a class 1 indications to undergo stress echocardiogram. So these are populations of patients with obstructive epicardial disease. And we do from the know from the Everest study that some of us on the panel have been part of in recruiting patients, that a stress echogram has got an excellent real-world practical performance in 31 UK hospitals, recruiting more than 5,000 patients and 6 months follow-up. I've got a negative predictive accuracy of 99%, an excellent rule-out test. And a positive predictive accuracy of 83% is also remarkable. So that was for the IOCA patients with obstructive epicardial disease. Now, what's the value of stress echo in patients with angina who have got non-occlusive coronary disease? Now, what is the scale of the problem here? I'm going to show you some of the facts and argue how big of a problem this is. 50 to 70% of women and 30 to 50% of men undergoing invasive coronary angiography for angina will have non-occlusive epicardial coronary disease, less than 50% stenosis. In the ischemia trial that most of us are aware of, more than 10% of patients with more than moderate ischemia on functional testing have non-occlusive coronary arteries, i.e. INOCA. INOCA can also coexist with disease in the main coronary arteries, epicardial arteries that are flow limiting as well. So they can have both INOCA and microvascular angina vasoreactivity and significant epicardial artery disease. Very important. And that's why sometimes we do see patients undergoing revascularization by means of a percutaneous intervention, and they still come back with angina symptoms because they have got comorbid conditions on the microvascular side. To identify INOCA endotypes is very important to allow us to do mechanism-specific management and to improve prognosis and symptoms. The current diagnosis for INOCA, unfortunately or fortunately, is based on invasive coronary physiological assessment. And this is a study that has been published by the team that looked at the stress of patients on stress spectrum and at all of these patients positive outcome, that is happening inducing stress.
Sorry, Professor Kardos, we're losing your vocals a little bit there. I'm not sure if there's a bit of a signal dropout.
I do apologize. Can
Lovely.
you hear me?
You're back. Lovely.
I do apologize. I've got a sky high speed internet. Should not be, but there we go. I hope you heard me thus far. So this is the Mayo data to show that all patients who had abnormal or inducible ischemia on stress echogram, they underwent invasive coronary angiogram that showed that 36% of the patients with no or had no epicardial coronary disease or less than 50% luminal stenosis, i.e. INOCA. More importantly, those patients who had epicardial coronary disease and or no epicardial coronary stenosis, they had exactly the same prognosis over the 5 years follow-up period. So INOCA has got a prognostic value. So let's talk briefly about the invasive physiology. How do we assess and diagnose INOCA patients? I won't talk too much about it, but that's the most important slide probably that we need to look at to understand the coronary physiology in the cath lab. The fractional flow reserve or the non-hyperemic pressure ratio are the ones that are assessing the epicardial coronary degree of epicardial stenosis, i.e. whether they are flow limiting or ischemia producing or not. The IMR or the hyperemic microvascular resistance measurements, whether it's thermodilution or Doppler based, assessing the microvascular circulation. The coronary flow reserve assesses both the epicardial coronary arteries and the microvascular coronary arteries equally. It's very important to note that those patients who have got non-ischemic epicardial or non-obstructive epicardial coronary disease, i.e. their FFR value is normal or higher than 0.8, the CFR only resembles the microvascular circulation, and that's important for our INOCA population who have got no epicardial coronary disease. So what do these consensus documents on INOCA suggest to us? 3 steps. One of them is to look at the coronary arteries. If those patients with angina have got mild or normal coronary arteries, they will undergo guided by a testing by adenosine to look at 3 parameters. These the FFR, the CFR, and the IMR. Those patients who have got no epicardial coronary disease, i.e. the FFR is more than 0.8, they will have further testing for CFR and IMR. The coronary flow reserve more than 2, or the myocardial vascular resistance index of less than 25 are normal values, which means that microvascular angina or coronary microvascular dysfunction could be ruled out. Those patients in whom the CFR is less than 2 and the IMR is more or equal than 25, they have got the diagnosis set up till now in stage 2, step 2 of a microvascular dysfunction. The third step is to look for vasoreactivity by acetylcholine, which is the endothelium-dependent vasodilator agent, which in endothelial patients with endothelial dysfunction, they cause paradox vasoconstriction. So those patients who have got no microvascular dysfunction and they have got no vasoreactivity on acetylcholine, then only we can say that patients have got non-cardiac chest pain. Those patients with no microvascular dysfunction, but vasoreactive positive, that is a significant vasospasm, more than 90% luminal reduction on acetylcholine test, plus angina, plus ischemic ECG changes, being it ST elevation or depression in more than 2 consecutive leads, they are diagnosed with epicardial vasospastic angina. Patients in whom the CFR and IMR are positive or abnormal, showing or in keeping with coronary microvascular dysfunction and have got no vasoreactivity, they are the ones who have got purely microvascular angina. And those patients in the same microvascular dysfunction group who have got positive vasoreactivity, whether it's with angina and ischemic changes, whether it's causing less than 90% or more than 90% epicardial coronary diameter reduction, they will have either microvascular or epicardial vasospastic angina and microvascular dysfunction. So these are what we call INOCA endotypes. There's another way of presenting it based on the invasive measurements of FFR, CFR, and IMR to diagnose or rule out coronary microvascular disease, and a provocation test with that can look at the epicardial or microvascular vasospastic angina. I've made a quick calculations. With all these overlap, we can have probably 7 phenotypes, of which we can probably assess and diagnose 5 of them, because these overlaps of the 3 circles cannot be identified separately, and neither can we differentiate between the those patients have got both epicardial or microvascular vasospastic angina at this moment in time. So what do the guidelines say? Those patients with INOCA have got 2A indication of undergoing invasive coronary physiology to measure these 3 parameters to differentiate between INOCA endotypes. Can we do it differently? Can we use non-invasive coronary physiology to compete with the invasive physiology to make a diagnosis of INOCA? And that's my next part of the talk here. So value of stress echo, that's where it will come as a new entity. We have got major problems. Of course, 60% of patients with angina who have got no obstructive epicardial coronary disease, we cannot take them straight in the cath lab and do invasive coronary physiology because there is no capacity in the cath lab, let alone our interventionist colleagues, they do not like to see non-occlusive coronary arteries where they cannot put any stents in them and just do coronary physiology. So this is a huge capacity problem facing us in diagnosing patients with INOCA. We need a safe, accessible, cost-effective, and accurate diagnostic modality to deliver the diagnosis of INOCA and subsequent prognosis. And the endotypes of INOCA should be identified to make sure that we do deliver personalized care to patients. Would the multiparametric stress echo be the answer? Let's have a look. multiparametric stress echocardiography takes up two entities. The one that we always look at, the ischemia detection by looking at wall motion abnormalities, and coronary sonography by looking at the coronary arteries, at the epicardial arteries, and measure the flow velocity in there. The recommendations currently suggest the distal LAD, because that's the easiest to visualize. Identify the distal LAD and put the pulse wave Doppler sample volume into it and measure the flow velocity. The flow velocity reserve, therefore, will be the ratio between the hyperemic distal LAD flow divided by the resting distal LAD flow. Anything is higher than 2 is associated with good outcome and the deferment of microvascular angina. What do the recent guidelines say about this? Stress echocardiogram derived INOCA assessment using coronary flow velocity reserve has got a 2B class of recommendations, which considers to be a maybe indicated paradigm. What we are doing to look at inducible ischemia and coronary flow velocity reserves. And we identify then subtypes of INOCAs. Those patients have got no inducible ischemia and normal coronary flow reserve. Clearly, they're at low risk for cardiovascular events, and they can be safely discharged with risk factor modification instructions. And depending on whether we can induce ischemia, i.e. regional motionality, or a plus minus coronary flow reserve being abnormal during stress echocardiogram, we can identify or diagnose 3 different subtypes of INOCA, that all of them have been associated with elevated risk of major outcome, and that is all-cause mortality, cardiovascular mortality, non-fatal myocardial infarction. How does the delivery of coronary flow reserve looks like? So we need to position a patient in a lateral position, much more lateral than any other stress echo situations. And we have to make sure that they are not supported too high up on the head end. We then have to identify the distal LAD, the course of distal LAD, which is usually in the anterior interventricular sulcus. We need to get the anatomical reference position and deliver ultrasound signals with appropriate probes that has to take into account frequencies that could be actually be anything between 2.5 to 4 or 5 megahertz is sufficient to image coronary arteries. Once we identify the coronary arteries, we have to make adjustment in a color Doppler scale between 15 and 25 centimeters per second. We are using Wolf filters, high Wolf filters, and pulse wave Dopplers at low filter, and the focus should be on at a depth that is not highlighted in this panel, should be between 15 and 10 centimeters. Of course, there are pitfalls which I'm not going into it, but the validity is clearly set. So that's how it looks like. Then we do a distal LAD flow measurement. So either low parasternal long axis view or apical 3-chamber view that we are foreshortening, bringing it up to 1 intercostal space higher, where we identify this interventricular groove, and this triangle shape is the one that tells us that we are in the right position here, and that's the interventricular anterior groove, and we expect the LAD, the distal LAD, to appear in this corner, like this. So you can see this red dot here is my LAD, and you can see once a bit of an angulation of the probe towards the anterolateral wall, you can see in its length. Once we identify the distal LAD, we put the PW sample volume into it to acquire the flow velocities at rest and during peak stress. And the ratio between the flow velocity at peak divided by the peak velocity at rest will give us the coronary flow velocity ratio. The coronary flow velocity ratio could be assessed under different circumstances during stress echogram. In those who have got normal coronary arteries, of course, we expect a normal coronary flow reserve, and that sets the diagnosis of the normal finding. Those patients who have got epicardial coronary artery disease can have, of course, reduced coronary flow reserve as well. Patients who have got non-occlusive coronary arteries and abnormal coronary flow reserves, they are setting the diagnosis for microvascular disease. The transthoracic Doppler-based coronary flow reserve has been validated against invasive flow wire Doppler flow wire measurements in this paper, with good correlation and good agreement. There's a validation study to look at the primary outcome of all-cause mortality, cardiovascular death, MI, heart failure in patients who underwent Doppler echo-based coronary flow reserve measurements during stress echocardiogram. You can see that of the 10,000 cases over the 5 studies, with total events of 1,043, which is 10% or so, 60% had non-occlusive coronary arteries. Slightly different cut points for coronary flow reserve between 2.4 and less than 2. You can see that the primary outcome has been highly positive to predict worse prognosis in those patients who met these cut points. I have highlighted and circled the 2 studies that have only recruited INOCA patients. You can see the hazard ratio of 1.9 and also more than 4-fold increase in the outcome. You can see also the stressing agents are a variety of them, both vasodilator stress, dobutamine stress, and even exercise stress, which is almost the most challenging part to do coronary assessment. So I'm coming to the last part of my talk here, showing some coronary flow reserve measurements during dobutamine stress echocardiogram and how it works in a daily routine. This is a patient, 66-year-old man with a few months history of epicardial angina, was referred for dobutamine stress echo, and the test was terminated at the end of protocol above the target heart rate due to progressive angina and also end of protocol. He had no resting bone motionality, and during peak stress, he had extensive apical thinning and dyskinesis. The coronary flow velocity in the distal LAD at rest was already significantly reduced to 10 centimeters per second. Just for those who are not very familiar with that, the normal velocity in the distal vessels should be at this LAD should be at least 13 or 14 centimeters per second. Someone who has got less than that, they already declare themselves to have a significant epicardial coronary disease. Why the distal flow is so low? And that was confirmed on the invasive craniogram with this very tight proximal LAD disease. So this is to show that multiparametric echo stress echogram has got a role to play on diagnosing patients with obstructive epicardial coronary disease. These patients underwent coronary angioplasty to the LAD, and a year later he was re-referred for a sequential stress echocardiogram for assessing the bystander, the right coronary artery and left coronary lesion. You can see and appreciate also the reproducibility of the stress echogram in the same patients after intervention, and the information we can gather from here. So these patients, stress echo this time showed no inducible ischemia during peak stress, and the coronary flow reserve was 2.59. You can see the resting flow velocity was 17 centimeters per second once the lesion of the proximality has been sorted out. Remember, the previous was at, before angioplasty 10 centimeters per second. So multiparametric stress echocardiogram can clearly give us indication about normal coronary physiology and therefore low risks. I'm going to show now the INOCA endotypes related images that we did here of a 50-year-old man with history of angina with prior angioplasty but recurrent typical angina, which tells you again about the coexistence of epicardial coronary disease and potentially microvascular angina. Patient underwent dobutamine stress echo test was terminated at 86% of target heart rate due to progressive chest pain symptoms. And he had also apical segments dyskinesis, although smaller degree than the previous patient had. His coronary flow reserve ratio, the flow reserve was 1.76, less than 2, in keeping with reduced coronary flow reserve. This gentleman has had no epicardial disease with maintained LAD patency after stent insertion. The diagnosis of an INOCA and microvascular dysfunction has been made. And that's, again, a very important proof. And that's the constellation we normally see most of the time in patients with INOCA, that have got inducible ischemia and we have got reduced coronary flow reserve and non-occlusive coronary arteries. And you can see from this paper from the Italian group that those patients who had got positive stress echocardiogram and reduced coronary flow reserve, this in red, has got very high fold higher event rates of overall mortality compared with those who have got no inducible ischemia and normal coronary flow reserve. The second INOCA endotype for multiparametric stress echogram was this 40-year-old man who had got history of coronary disease, ongoing typical chest pain symptoms. He underwent dopamine stress echo that was terminated at the end of protocol, again, 85% target heart rate, that showed very mild degree of dyskinetic apical segments, but the coronary flow reserve was normal. So 77 centimeters per second during peak stress, hyperemia, and 33 centimeters per second during baseline. So this is normal coronary flow reserve, but inducible ischemia positive. Now, this, of course, raised the diagnosis of INOCA, but potentially normal coronary microvascular circulation, as far as we know for the time being, for the modalities that we have got available to use. Of course, we have not looked at vasoreactivity, myocardial bridging in these patients either. Is it important? Yes, it is. And you can, I'm coming back to this 4 years overall mortality outcome paper to show that those patients who have got a positive dopamine stress echo, but normal coronary flow reserve, this in green, have got 3-fold higher event rates or overall mortality compared with those who have got negative stress echo and normal flow reserve. So prognostically, it does matter also, although sometimes we are querying the pathophysiology behind that. The last INOCA endotype is demonstrated in this 64-year-old woman who underwent dopamine stress echo. It was some chest pain symptoms, and that showed that she had no inducible ischemia. That's the peak stress I'm pointing at, with no wall motion alveolity, neither at rest nor during peak. And the coronary flow velocity reserve in the distal LAD was measured to be 1.57, abnormal. So we have identified microvascular dysfunction without inducible ischemia. Does it matter? Yes, it does. This is the set of comparison on 400 plus patients of a different Italian group that looked at patients with no inducible ischemia, but reduced hyperemic flow velocity reserve during stress echogram, and those patients who had reduced flow reserve but no inducible ischemia had poor 2 years prognosis. So we have then drew up this non-invasive clinical decision pathway for suspected INOCA populations to make everything non-invasive. So going just quickly through this, if we have got a patients with angina, we do refer them for a cardiac CT angiogram to rule out underlying coronary disease or to verify coronary disease. If the CT angiogram shows non-occlusive epicardial coronary artery disease, then INOCA phenotype, then we can potentially refer to the patients for multiparametric stress echogram, looking at regional wall motionality, i.e. inducible ischemia, and distal LAD coronary flow velocity reserve. And these are the endotypes that we are going to find ourselves with dependent on positive for ischemia and or abnormal for coronary flow reserve, or the mixture of these two parameters. We know that those patients with no inducible ischemia and normal flow reserve, they are at low risk of MACE, and the others, all three of them, are at high risk that we cannot ignore. We then have to make lifestyle adjustment, risk adjustment, and appropriate anti-channel medications as recommendations. In summary, the value of stress echo in patients with angina, in particular INOCA, thus multiparametric stress echocardiography will be the future modality, maybe. Multiparametric stress echo provides with accessible bedside assessment that is scalable, is at low cost, it's safe with no radiation, accurate diagnosis of coronary disease with epicardial coronary disease can be made, and potentially INOCA endotypes could be identified. It prognostifies patients both with IOCA and INOCA, and in INOCA populations, potentially it helps mechanism-specific management to improve both symptoms and prognosis. I just put a few points here for the future where we could go from here. The needs to develop multiparametric stress echo protocol to include all INOCA endotypes, in particular vasoreactivity assessment. Multiparametric stress echo in INOCA needs, of course, validation against invasive methods to look for accuracy and also outcome. And once we have done that and we have got a genuine class 1 indication for multiparametric stress echo, we will need to also have an RC randomized control trial to see whether we can influence management by using INOCA, by multiparametric stress echo based INOCA diagnosis and prognosis. Unfortunately, as my last slide to show that all the prospective registry trials, as well as the randomized control trials currently recruiting into INOCA assessment, is using invasive diagnostic tests only. So we clearly have got lots to do to look at the future value of stress echocardiogram, in particularly targeting this high number of populations of INOCA patients who sometimes have been ignored in the past as non-cardiac chest pain patients. Thank you very much.
Professor Kardos, thank you very much. It was a fantastic presentation. It's very topical at the moment. And I think I personally know how daunting it is to try a new technique, especially if it's quite challenging technically. And I suppose, you know, your diagnosis is only as good as the information that you receive. And I have a few practical questions for you relating to, you know, to the actual skill, to the actual technique. Now, one of the questions is that, so we're obviously relying on making Doppler measurements in the carotid arteries. And there's a question, someone's asking, how can we make a diagnosis by only measuring the flow in one coronary artery?
Yeah, this is an excellent question. And the whole talk was not to use coronary flow velocity measurements to diagnose obstructive epicardial coronary disease, because that can be done, but then you need to develop your skills to image all the 3 coronary arteries by echogram, which is very, very difficult, and the reproducibility is very. What has been proven to be relatively easy is to look at the distal LAD that certainly lends itself the easiest way to assess coronary flow in, and therefore to assess microvascular function potentially. Is it a good enough technique? Probably not, because we do know from some of the papers that microvascular dysfunction can be patchy and not necessarily related to a single coronary territory, but others as well. At the moment, there's no trial or not even observational reports to show that how easily you can assess distal right coronary or distal circumflex optoflangeal branch flow velocity reserves. What the whole community is looking at, those who have got some sort of experience in coronary flow measurements, is to make it as simple as possible, to at least provide some value to those high volume patients who at the moment are not getting investigated for the INOCA because there's no cath lab capacity, and also there is no know-how if you were to stick with the 3 coronary flow reserve assessment. No way that a stress echo protocol can accommodate this. My kind of thinking was, and that's, I'm sharing with others as well, almost certainly, who are into this INOCA forums, that we have to develop a simple protocol that at least helps, maybe not to the 100% exclusion, but helps to make identification of microvascular circulation related issues or problems. And at the moment, until we have got better technique or technology by ultrasound equipment to assess coronary arteries in all 3 coronary arteries, we don't have better than the distal LED to look at. I know it's not 100% correct, but that's what we have at the moment and can potentially give some support in our angina patients who do not have epicardial coronary disease to classify them as a INOCA with microvascular disease, and you then know what type of medications you may wish to give them. What I'm also very keen to think about is to bring the vasoreactivity to this non-invasive setup assessment. We need to have, I'm not talking about either intravenous or intracoronary acetylcholine or agonovin injection in patients during stress echoes, which currently is the invasive cath lab-based assessment of vasoreactivity. But think physiology. Coronary spasm can be caused by physiological maneuvers. And that's what I'm trying to think of, how to get a protocol established to do a physiological, non-invasive stimulation test to the coronary arteries that potentially can cause vasospasm. Without going into details, we do know that hypercapnia or hypocapnia, that is low CO2 values, can cause vasospasm. And I'm not telling you much more because I'm over.
That's a whole other lecture, yes. There's a few other questions, and hopefully at the end, if we have some time, we can go back and revisit this topic. Thank you very much.